Now in the mandible, we have radiolucent landmarks and radiopaque landmarks as well. Okay, so the radiolucent starts with the symphysis. Symphysis, as you know, it is in the midline region of the mandible. You will see a radiolucent line, especially below 2 years of age. Okay, by the end of first year of age, that means by the end of first year, that means when the child becomes two, the symphysis you should usually fuse. Okay, if you see a radiolucency in the symphysis area in a person more than 2 years of age, then either it can be a fracture if there is a history of fall, or it can be a cleft of the mandible if the patient does not have any history of fall. Okay, so symphysis is significant to be differentiated it from a fracture line or of a cleft. So the age is very important. Okay, by the end of first year, that means by the time the patient is 2 years of age, you should not be seeing the radiolucency in the symphysis region. Okay, now lingual foramen. So in the skull, you can see a small foramen in the lingual aspect of the mandible. Okay, so this foramen will be surrounded by some radio opaque projections of bone called as genial tubercles. Okay, so what you see here in the anterior mandible, the radiopacity is the genial tubercle region, and the radiolucency is the lingual foramen. Okay, lingual foramen is the radiolucent part, and the radiopaque part is called as the genial tubercles. Okay, so genial tubercles are usually very prominent when it comes to the edentulous mandible. Okay, because edentulous jaws undergoes more resorption than the jaws with the teeth. Okay, so in the periapical radiograph, we are going to find the structure in the midline region of the mandible. Okay, a radiopacity, that is the genial tubercles, and the radiolucency in center is your lingual foramen. Okay, so as we discussed, edentulous mandible, genial tubercles are more prominent, and it has to be differentiated from other pathologies. Now coming to mental ridge. Mental region means premolar to premolar region. Okay, so ridge always means it is a linear radio opacity in the radiograph, and in the skull it is a linear prominence of bone. Okay, so if you feel your chin area in from the midline towards the side, there is a prominence of bone on both the sides. Okay, so this prominence is called as the mental ridge. So in the radiograph, this prominence will appear as the radio opaque lines on either side of the mandible. Okay, so you can see the mental ridge on either side of the mandible as thick radio opaque line. What you see here is the genial tubercles, and this is the inferior border of the mandible in the anterior region of the jaw. Now, nutrient canals. So as the name indicates, the nutrient canals are small canals that supplies nutrition to the surrounding teeth. Okay, so these nutrient canals, they open up into the apical foramen and pass the supply of nutrients via blood vessels and nerves to the teeth in the pulp area. Okay, so sometimes there will be prominent nutrient canals. Okay, in such cases you should suspect a higher blood pressure or advanced periodontal diseases. Okay, so this has to be differentiated from the periapical pathologies in the same area. So nutrient canals, how does it look? In the anteriors, it looks like vertical line, radiolucent line, and in the posteriors also it is like vertical radiolucent line. What is the difference? Here in the anterior, you can see more radiolucency surrounded by radiopaque borders, whereas in the posteriors, you will not see radiolucency much. You will see just two radiopaque lines. So these are called as nutrient canals, which supplies nutrition to the region. Okay. Now the next landmark is mental fossa. Mental fossa is again seen in the mental region. That means premolar to premolar region in the anterior region of the jaw. So just below your incisor teeth, you will feel a small depression above the mental ridge. Above the mental ridge, below the incisor teeth, you will see or feel a small depression on the lateral aspect or outer aspect of the anterior mandible. This is called as the mental fossa, and you have to always check mental fossa region for any pathologies. Okay, if you can see trabeculae inside the region, if you can see the lamina dura and pedial space of normal thickness, then you say that it is normal. If there is a break in lamina dura, if there is increase in the width of pedial space or decrease in the trabeculae, you say that there is a pathology. Next is your mental foramen. You already know what is it. It is a radiolucent area which is circular in shape, and it is usually present between the premolar region. Okay, so it should be always differentiated from a pathology. Okay, how does it look? It looks like a circular or oval shaped region between the premolar or beneath the first premolar or second premolar, depending upon the race. Okay, it's always directed superiorly and forward. Okay, and it is usually well defined. So the point that it is well defined should be able to differentiate it from other pathologies. Okay, now if the mental foramen is superimposed on the teeth and you're not able to differentiate between a mental foramen and a periapical pathology, you have to use slob technique. Okay, slob technique will help you to differentiate between the mental foramen and the periapical pathology. Now coming to the mandibular canal. So canal always has radiolucent area surrounded by upper radiopaque border and lower radiopaque border. Okay, so it is like a radiolucency surrounded by two lines of radio opacity. Okay, so this is how a mandibular foramen, mandibular canal looks like. Radiolucency surrounded by radio opaque margins. Okay, radio opaque margin on the upper side, radio opaque margin on the lower side. Here again, you see edentulous mandibular ridge with radio opaque upper margin, radio opaque lower margin, and the radiolucency in between. Okay. Now coming to submandibular gland fossa, it's seen in the posterior region of the mandible as a diffuse radiolucency. Okay, it is usually located beneath the myelohyoid ridge. Okay, this is the myelohyoid ridge marked by the upper arrow, and there is a depression in the lingual surface of the mandible which lodges the submandibular gland. So in the radiographs, this depression is seen as radiolucency. Okay, sometimes it is seen below the myelohyoid ridge, and sometimes it is seen overlapping the myelohyoid ridge if your angulation is foreshortened. Okay, so here this is the myelohyoid ridge. As we discussed, the ridge is a linear radiopacity in the radiograph. So here you can see the myelohyoid ridge in the periapical region of the molar teeth. Okay, so you can see here in this image, this is the submandibular gland fossa overlapping with the myelohyoid ridge. Okay, here this is the submandibular gland fossa beneath the myelohyoid ridge. So the location of submandibular gland fossa is the posterior region of the mandible, but sometimes the myelohyoid ridge is seen overlapping that area. Okay, now coming to the last few anatomical landmark, what you see here is the external oblique ridge. Okay, external oblique ridge. Now the external oblique ridge always ends towards the crown of the tooth. Okay, if you see the black arrow, it is the external oblique ridge ending towards the crown of the tooth. And you have something called as internal oblique ridge. Okay, so here what is seen is the myelohyoid ridge, right? So myelohyoid ridge is always seen in the periapical region. External oblique ridge is seen in the coronal region. Okay, the crown region of the tooth, not in the periapical. So the starting point of the myelohyoid ridge, sometimes you call it as internal oblique ridge. Okay, so this is the internal oblique ridge starting in the molar region periapically and continuing down or forward as myelohyoid, and the upper one is your external oblique ridge. Okay, then comes your inferior border of the mandible. Inferior border of the mandible is made of cortical bone, so it is obvious that it's going to be thick and radio opaque always. So any pathology which is expanding can cause a destruction of the inferior border of the mandible. So it is an important landmark when it comes to pathologies. The last one is your coronoid process of the mandible. So it appears on the radiograph of the maxillary posterior region as a triangular radiopacity. So when we discussed the maxillary landmark, we said that a triangular radiopacity is seen in the posterior region of the maxillary molar region or molar radiograph. It's called as coronoid process. That is the only structure in the mandibular landmark that is seen in maxillary posterior tooth. Okay. Now, the last section is restorative materials. So restorative materials, it can vary from radiolucent to radio opaque. Okay. The same material, depending upon its composition, can be radio opaque and radiolucent as well. For example, if you see here in the list of radio opaque materials, you can see most of them are metals. Okay. Then comes your calcium hydroxide, gutta-percha sticks, silver point, and composite. So composite is seen both as radio opaque as well as radiolucent because of the difference in the composition. Okay, the mainly radiolucent ones are the silicate cements, composite restorations, porcelain, and orthodontic bands and appliances. Okay, so in the radiograph, what you see here, it's restorative material, mainly amalgam. Okay, here also you can see a restorative material. In the third radiograph, you see a small extension radiopacity, which is called as pin retained restoration. Okay, for extra retention, in some cases with the very heavy filling, you drill a hole into the dentine and put a pin into the dentine for extra retention. That is called as pin retained restoration. This is a crown cap. Okay, and what you see here is the bridge. Okay, here what you see as a circular area is the orthodontic bands. The one with the prominence is called as orthodontic brackets. Here what you see as thin radiopaque line is called as silver points, which is a root canal filling material that was previously used. And what you see here is the gutta percha sticks or the cone. So restorations, how to differentiate between restorations and caries. This is a porcelain fused to metal crown. This is the metal portion of the crown, and this is the porcelain region which appears as radiolucent. Okay, when you see the borders of the radiolucency as very well defined, it means that a cavity has been prepared and it has been restored. So it is a composite or a silicate restoration. But when you see that there is an irregular area of radiolucency, you should always suspect it as a caries. Okay, now here you have a radiopacity, which is the base, and you have the radiolucency, which is the composite or the silicate fillings. Okay, that's how you differentiate between restorative materials. Okay, now if you have any questions, you can let me know.